Okay, I think we'll make a start. Thanks everyone for joining, and feel free to put your video on as well, so we can see and make it a bit more human. Yeah, thanks for joining today. So this is the second in our inaugural lecture series, which is celebrating the incredible honorary MAHSC clinical chairs. So today we have Raffaele Califano, and Fiona will introduce him. Feel free to ask questions in the chat or at the end of Raffaele's talk, and we'll cover those in around 20-25 minutes. So yeah, look forward to celebrating Raffaele today, and yeah, feel free to share questions. I'll hand over to Fiona now. Thanks everyone.
Thank you very much, Jane, and hello everyone. I hope that you're getting a bite to eat at this inaugural lecture session. It's a real privilege and pleasure for me to chair it and to celebrate my colleague's success in this honorary clinical chair. Congratulations, Raffaele. It's also making me feel a little old. For those of you who don't know me, I'm Professor Fiona Blackpool. And I first met Raffaele when he came to the Christie to do a clinical fellowship in the mid-noughties. He is from Italy, and he graduated from the University of Perugia, a beautiful place if any of you have been there. He then, after completing his specialist training in medical oncology, came to Manchester. He fell in love with the city and the weather, and he has been here pretty much ever since. He was appointed as consultant to the lung team in 2012. It's been a real privilege for me to watch his career progress. He's been an investigator for multiple clinical trials through phase 1B to 3 in the real heyday of lung cancer treatment development, with developments in targeted therapies, immunotherapy, deeper understanding about never smoking lung cancer in never smokers. So there has been a huge step change in treatments for lung cancer that Raffaele, together with international colleagues, has steered. And he's also worked intensely in the ESMO group with the ESMO young oncologists. And then once he got to a certain age and was no longer eligible to be on the young oncologist group, ESMO publishing group, also the EORTC lung group, British Thoracic Oncology group, and the International Association for the Study of Lung Cancer that we often describe as World Lung. So he's authored over 100 papers. He has a very busy clinical practice, and I'm looking forward to hearing from him over the next 20 minutes or so, opportunity for you to reflect, Raffaele, and share with us. So over to you.
Thank you very much, Fiona, and good afternoon, everybody. It's a privilege for me to be here and share with you my journey and my clinical and academic interests. And also, I like to share with you the future challenges and opportunities for myself and the team. So as Fiona mentioned, I'm from Italy, and I did train in medical oncology in a beautiful town in central Italy, which is called Perugia. And as part of my last year medical oncology training, I was given the opportunity to go to a center of excellence to spend some time. And that's how I ended up for the first time at the Christie in 2005. And I had an honorary fellowship with the lung and melanoma team for 6 months. Then I got back, I completed my training in medical oncology in 2007. And then I came back to the Christie for a formal clinical research fellowship with the lung and melanoma team that had to be for 2 years. But then I ended up staying for two years extra until 2012. And then I was appointed that year as a consultant medical oncologist at the Christie. So little I knew that my experience in 2005 at the Christie in Manchester may have changed my life. And sadly, as part of my training, these are 3 people that I have a lot of credit for, and they've acted as mentors and sponsors. And I'd like to acknowledge Professor Nick Thatcher, who is now retired, and Professor Fiona Blackpool, who is sharing today, and Professor Paul Lorigan. They have given me an enormous amount of opportunities, and clearly they made me work for it. But without them, I wouldn't be where I am and where I am. There's been a number of other people along the way, Professor Mansour, Dr. Yvonne Summers, Professor Fairfield, and Professor Balle, who throughout the years, they've given me a lot of advice on clinical practice, but also on career. And certainly, they've played a major role in my development. I focus on thoracic oncology, so I only treat lung cancer. I have a large clinical practice at the Christie and Wythenshawe. And my main interests from a clinical practice perspective have been treatment of oncogene-driven non-small cell lung cancer with targeted agents, in particular, tumors harboring EGFR activating mutation or ARC gene rearrangement. And then I've also developed a special interest in immunotherapies with immune checkpoint blockade for lung cancer. And the last 10, 15 years have been fascinating for thoracic oncology. First of all, thanks to a better understanding of the molecular biology of non-small cell lung cancer, we're now able to identify a number of molecular aberrations which can be actioned with targeted therapies. And these are, for example, the EGFR activating mutation, ARC or ROS1 G rearrangement, RET rearrangement, KRAS G12C. And what is clear is that if we are able to identify these genomic molecular aberration or oncogenic drivers, and we can match them with the right targeted therapies, we are able to improve survival and outcomes for our patients with better quality of life, certainly compared to the old style chemotherapy that we used to have as the only weapon for these patients up to 15 years ago. And just to show you how quickly the field is moving, I put on this slide a timeline for the FDA-approved therapies for oncogene-driven non-small cell lung cancer. And the biggest change has happened over the last 10, 12 years. You could see how many drugs are now available for each oncogenic driver, from EGFR, ROS to RET or MET exon 14 skipping. And I'm expecting that as we go ahead with further research, the number of agents and the number of actionable molecular aberrations to be added to this slide over the next few years will increase at a very, very fast pace. Another fascinating piece of research and certainly implications for clinical practice has been the understanding of the interaction between the tumor cells and the immune system. And we're now able to harness the immune system via immune checkpoint blockade, and we can use and direct the T cells to unleash an anti-tumor response. So we are now able to use monoclonal antibodies as systemic anti-cancer therapies for a number of disease groups, but this is particularly relevant for lung cancer. And for people who are online and not very familiar with the anti-tumor response via T cells, I like to summarize it in a very simplistic way. In reality, this is very, very complex. So the tumor cell will release antigens, which will be captured by the antigen presenting cells, will migrate, find the inactive T cells. After this encounter, the T cells will be activated, they will proliferate, and will differentiate in T effector and T memory cells. And the activated T cells will go seek and destroy the cancer cells, therefore stimulating an effective anti-cancer response. But these responses finely tuned as we have a number of checkpoints which are able to modulate the immune response. And these are expressed on the T lymphocyte surface. We have co-stimulatory signals such as CD28, OX40, or CD137. But we also have inhibitory signals by inhibitory receptors such as CTLA4, PD1, TIM3, or LAG3. And under normal physiological circumstances, the binding of these immune checkpoint ligands to the receptors act in maintaining immune self-tolerance and also at protecting the tissues during the immune response to cancer or to a pathogen, and therefore decreasing the risk of autoimmune disease. Very relevant for clinical practice is the interaction between PD1 and PD-L1. The T lymphocytes will recognize the tumor cells and will bind to the major histocompatibility complex by the T cell receptor, and they will induce an immune response. The tumor cell obviously wants to survive and will try and shield itself from the attack from the T lymphocytes overexpressing in their surface PD-L1. The PD-L1 will bind to PD-1 and basically will shut down the T lymphocyte response. And this PD-1 to PD-L1 interaction acts as a brake to the immune system. And now blocking either PD-1 or PD-L1 via monoclonal antibodies, we are removing the brakes, and therefore we are stimulating the immune response against the cancer cells. And the results that we have seen with these drugs are astonishing. I'll give you a couple of examples, mostly in the advanced setting. This is a landmark study, KEYNOTE-24, where single-agent immunotherapy with pembrolizumab was tested against standard chemotherapy in patients with advanced non-small cell lung cancer whose tumor had a high expression of PD-L1, which is the only biomarker that we can use in clinical practice to select patients who are most likely to benefit from immunotherapy. And this study showed how people who received immunotherapy pembrolizumab had a much longer survival at 26 months versus only 1 year compared to standard chemotherapy. But what we also know is that for patients who receive immunotherapy, some of them, they may derive a sustained and long-term response. And the data I'm presenting here is the 5 years overall survival data from KEYNOTE-24. And this clearly shows that up to 30% of patients who received immunotherapy are still alive at 5 years. And we're talking about advanced metastatic non-small cell lung cancer, which is certainly unprecedented. And if someone would have told me about these results 10 years ago, I thought this was completely crazy. But also the combination of chemotherapy and immunotherapy works very well in patients whose tumor either do not express PD-L1 or have low PD-L1. Again, 2 landmark studies evaluated the combination of chemo plus immunotherapy versus standard chemotherapy, again, demonstrating a much longer survival. And also, when you look at the 5-year landmark, approximately 18–19% of the patients will be alive at 5 years if receiving the combination of the chemo immunotherapy. And we are pushing our survival figures year after year, certainly changing the natural history of patients with advanced non-small cell lung cancer without an oncogenic driver. Together with clinical practice, I had the opportunity to be involved with a number of international oncology societies, in particular ESMO, which is the European Society for Medical Oncology, and ISLC. I was the chair of the ESMO Young Oncologist Committee after 2015. I was a member of the fellowship committee of ISLC up to 2019. And then as I aged, I couldn't be a young oncologist anymore, and I was elected chair of the ESMO Educational Publishing Working Group. And I'm still a member at present, and I've been an active member of the EORTC lung cancer group since 2017, contributing to design clinical trials. The experience working with international societies also gave me the opportunity to have some lead roles on international congresses. I was the member of the scientific committee for the ESMO Congress in 2018, and also for European Lung Cancer Conference the same year. I was the chair of the Thoracic Cancer Track at ESMO Asia Congress in 2018, and I've been the chair of the Small Cell Lung Cancer Track, a World Conference Lung Cancer in 2019 and 2022. I have a passion for teaching. I regularly teach undergraduate, the trainees, and the other healthcare professionals in clinical with dedicated teaching slot. But I also thought that was very important, and we have the responsibility to nurture the next generation of clinical oncologists. So in 2017, together with colleagues at the Christie, I set up the International Clinical Fellowship in Thoracic Oncology, which aims at giving advanced training in management of lung cancer, but also training in clinical trial design and delivery. And over the years, we've had the opportunity to attract brilliant fellows from Europe. These colleagues have been able to publish extensively and present findings at international congresses. On the slide, 4 of the most recent fellows, Dr. Anna Ortega-Franco, is still with us in Manchester doing the PhD with Professor Dyer and Professor Blackhall. Chris Ackerman, who went back to Switzerland and is now the Deputy Director of the Oncology Department in Thun. Dr. Laura Moliner from Barcelona, who recently left the team at the Christie and went back to Barcelona as a consultant in a very good institution. And the recent addition of the team is Dr. Igor Randulfa, who's been working with us in Manchester over the last 2 months. I also thought that given the expertise in lung cancer in Manchester at the Christie, we had to exploit the links with the European Society for Medical Oncology. And I designed the Christie ESMO preceptorship in lung cancer, which I currently co-chair with Professor Blackwell and another key opinion leader in Europe. This is a 3-day course that attracts more than 100 delegates each year from Europe. This is a free course to attend on an invitation basis, and the faculty is composed by 50% of Christie consultants and 50% are key opinion leaders from Europe. It started in 2014 and has been running annually, including during COVID, in a virtual format since 2016, and is regarded as one of the most comprehensive courses in lung cancer internationally. In terms of research, the team knows that I'm very passionate about research, and I've been able to lead on NCRI batched clinical trials on immunotherapy and molecular-driven targeted agents over the last 10 years. Together with the colleagues at the Christie, we have developed a research team which is capable to deliver large national and international studies, which are highly competitive in terms of global recruitment. I've been the chief investigator for the UK, and also I am and I've sat on several clinical trial steering committees. And in terms of research collaboration, I've been able to establish strong links with URTC and ETOP, lab collaboration with Professor Caroline Dyer's research group at the Cancer Research UK Manchester Institute, and also by the TracerX Consortium, links with the Cancer Research UK Lung Cancer Centre of Excellence at UCL with Professor Charlie Swanson's group. I'm going to give you 2 practical examples of practice-changing studies I was able to lead on and deliver with the support of the research team at the Christie. The first one involves patients with ALK gene rearrangement. And ALK gene rearrangement in non-small cell lung cancer is identified in approximately 5% of the patients. They have typically adenocarcinoma histology, and they usually, but not always, never smokers or light smokers, and these patients are usually less than 50. One of the characteristics of this disease is that there's a high chance of developing brain metastases, either present from the outset or approximately 30% risk in the lifetime. And therefore, from a drug development point of view, it's very important to have drugs which have a very good CNS penetration. Historically, the first drug to be approved for the treatment of ALK-positive non-small cell lung cancer has been Crizotinib, which is an ALK ROS1 and MET inhibitor, proven to be better than standard chemotherapy in a number of landmark studies, which are now several years old. Crizotinib is a good drug, but unfortunately is a poor CNS penetrant, and therefore the vast majority of patients will progress in the brain, which has got serious implications in terms of prognosis and quality of life for our patients. We know that eventually all patients will progress, and we have now an increasing body of evidence that tells us which are the most common mechanism of resistance. About a quarter of patients will develop secondary ALK resistance mutation. Together with that, we have also increasing the copy numbers, but also activation of bypass tracks, such as activation of EGFR, KRAS pathway. And also, there's still a lot of unknown mechanisms of resistance. Bearing this in mind, from a drug development point of view, it was very important to focus on second or third generation agents able to cover the presence of these secondary mutations. And this is in vitro data that shows that new drug, for example, alectinib, brigatinib, or lorlatinib, have a wider spectrum of activity on the resistance mutation to Crizotinib. And therefore, at a global level, I was part of a steering committee which designed these landmark phase 3 clinical trials called Alpha 1L. We enrolled patients with ALK-positive non-small cell lung cancer were never treated with a TKI, and patients were randomized to receive Crizotinib, which was the standard of care at the time, or Brigatinib, which is the second-generation ALK inhibitor with excellent CNS penetration. The primary endpoint of the study was progression-free survival by independent radiological review, but the trial was also designed in a way that patients who were randomized to Crizotinib could cross over to Brigatinib at progression. The study was a positive study. There was a longer progression-free survival favoring Brigatinib over Crizotinib, either according to independent review, but also according to the investigator-assessed PFS, 30 months progression-free survival for Brigatinib versus 9 months for Crizotinib, with a particular impact on CNS. In fact, patients who were randomized to Brigatinib had a 75% reduction of the risk of progression in the brain when compared to Crizotinib. And there was also a longer intracranial progression-free survival, which mirrored what happened extracranially, showing that Brigatinib was a very good drug in terms of intracranial and extracranial control. On the basis of the ALTA-1L study, Brigatinib has been now approved as a first-line option for ALK-positive non-small cell lung cancer who are treatment naive, and has been endorsed by the ESMO guidelines, NICE guidance, and also the ASCO and NCCN guidelines. I also have a special interest in small cell lung cancer, which is a very exciting and interesting disease, but unfortunately is very aggressive. And despite the initial high response rate to platinum-based chemotherapy, we know that in the vast majority of patients, these responses are short-lived, and the disease will therefore progress very quickly. And when you get to second line, unfortunately, the options that we have at present have got very limited efficacy. So we have to do better for our patients. There's been a lot of barriers to progress in small cell lung cancer. It is usually diagnosed on very small cytology samples. Compared to non-small cell lung cancer, the research attention is much less. We don't know a lot about mechanism of resistance to chemotherapy, and it also has a complex biology. In particular, most common mutations that we identify at genomic profiling are passenger mutation, and these are inactivating mutation of p53 or RB1. So differently than non-small cell lung cancer, these are non-actionable. On the other hand, though, small cell lung cancer is the perfect candidate for immunotherapy with immune checkpoint blockade because it has high tumor mutational burden, is an immunogenic disease, usually presents with paraneoplastic syndromes, and also has an immune suppressive phenotype with high Treg and low T effector cells. So there was a strong rationale to design this global study, and I was part of the core team and the chief investigator for the UK. IMpower133 aimed at testing the addition of immunotherapy with atezolizumab to standard chemotherapy versus chemotherapy alone in treatment-naive patients with advanced small cell lung cancer with good performance status. And the core primary endpoints of this study were overall survival and progression-free survival. The study was a positive study. There was a longer survival favoring the chemoimmunotherapy arm. And what was important to see was that there were some patients deriving long-term benefit, and that the landmark analysis at 18 months, a third of the patients are still alive in the chemoimmunotherapy arm, whilst only 20% of the patients are still alive in the chemotherapy arm. We also now have 5 years overall survival data with very interesting results, which will be presented at a forthcoming oncology conference. On the basis of the results from IMpower133, the combination of carboplatin etoposide plus atezolizumab was approved as a first-line option for fit patients by ESMO guidance, NICE guidance, and also the ASCO and NCCN guidelines. And it was my privilege to be able to offer this therapeutic strategy to the patients at the Christie 5 years in advance compared to when this regimen was actually available all over the world in clinical practice. But which are the future challenges? I think it's important to improve survival for patients with untreated advanced EGFR mutant non-small cell lung cancer. Despite first-line Osimertinib is very effective, As a matter of fact, the vast majority of patients will progress within 2 years of treatment. And we do need also novel strategies for patients who've been receiving osimertinib, and unfortunately the disease is now progressing. I have an interest in drug development for overcoming mechanism of resistance to anti-PD-1 or anti-PD-L1 immunotherapy drugs. And also we need to do better in the second line or third line setting for pre-treated small cell lung cancer patients. I'm going to walk you through a few examples over the last 5 minutes. Osimertinib is now standard of care as a first line for EGFR mutant advanced non-small cell lung cancer. Inevitably, within 20 months on average, patients will progress. And the mechanism of resistance could be either on target, and that is EGFR dependent, mostly the presence of a new EGFR mutation, most commonly C797S, but also we have some EGFR independent mechanism of resistance, such as transformation to small cell or squamous cell, or activation of bypass tracks, such as METHOR2 amplification, RAS mutation, or the presence of an ALK-RET fusion. And at the Christie, we're using these strategies to overcome potential resistance to osimertinib. We do have 2 investigational agents now on this MARIPOSA trial, amivantamab, which is a dual MET and EGFR inhibitor, which is a monoclonal antibody, and lazertinib, which is a 3rd generation irreversible TKI. The MARIPOSA study is evaluating treatment-naive patients with EGFR mutant non-small cell lung cancer will be randomized between osimertinib, lazertinib, or the combination of lazertinib and amivantamab. We've been top recruiter for this study in the country, and we're awaiting readout over the next year or so. In the post-osimertinib setting, we're also enrolling in the MARIPOSA 2 study, global phase 3 trial, evaluating patients who have failed osimertinib will be randomized between standard chemotherapy, carboplatin, pemetrexed, or the chemotherapy backbone with the addition of amivantamab or avimantamab and lazertinib with a maintenance phase. Although it is very important also to try and address the mechanism of resistance to immune checkpoint blockade, the interaction between the immune system and the cancer cells is very complex, but we're now being able to identify some intrinsic mechanism of resistance and some extrinsic mechanism. In a very simplistic way, intrinsic resistance may be due to the fact that the tumor lacks immunogenicity. So this is a cold tumor, usually low tumor mutational burden. There may be dysfunction in the new antigen presentation or aberration in several signaling pathways, such as the JAK1 or 2 pathway or Wnt or B-cadherin pathway. In terms of extrinsic mechanism of resistance, we may have factors which are most related to T cells, such as T cell exhaustion or activation of alternative immune checkpoints like TIM3. We may have a very immune suppressive microenvironment, or there may be some cytokines and metabolites which are released into tumor microenvironment, making it very immune suppressive and therefore dampening the impact of the immune response. Now we are addressing these in clinical research setting. At the Christie, we have the Coastal Lung Study. We are the UK Chief Investigator site, and this is evaluating patients with pre-treated non-small cell lung cancer who have been exposed to chemotherapy and immunotherapy, and now the disease has progressed. The standard option in clinical practice will be docetaxel. We're now randomizing between docetaxel or the addition of dostarlimab and cobalimab, which are novel anti-PD-1 and anti-LAG3 inhibitors, to see if the addition of these immunotherapy drugs will enhance the impact of docetaxel. In the small cell setting, we're also evaluating a new compound, MAHSC 7684A. The global co-principal investigator of this study, and the study is currently running at the Christie and internationally, and is evaluated patients with treatment-naive metastatic small cell lung cancer will be randomized to receive standard chemoimmunotherapy with the Empower 133 regimen that we led on at the Christie, or a combination of the same chemotherapy plus this new dual anti-PD-1, anti-TIGIT compound until progressive disease. And there's a very strong rationale for this combination. Finally, we're also looking at second-line and third-line study. The Lagoon study is an international study evaluating a marine-derived compound, which is a DNA-damaging agent, either as a monotherapy or combination of lurbinectedin and irinotecan versus standard chemotherapy in the second-line setting for small cell lung cancer. So these are very exciting times for clinical research in the field of lung cancer. I wouldn't be where I am without the support of several people throughout the years, and most importantly, the team at the Christie. I have the pleasure to work with fantastic medical oncology and clinical oncology colleagues as part of the lung team. I value the support of the secretary of a fantastic team of lung specialist nurses and research nurses. The clinical trials admin team works behind the scenes to make sure that we can set up and deliver the clinical trials. I've had the pleasure to work with excellent SPRs and fellows over the years, and certainly I've had a lot of help from international collaborators and from international societies who've given me a lot of opportunities. European Society for Medical Oncology, NSCLC, British Thoracic Oncology Group, and URTC. Thank you very much.
Thank you very much indeed, Raffaele. I can give you a round of applause virtually. It's fantastic to see what you have achieved and what is still going on. There's a lot more still to do. So we don't have a lot of time for questions, but you've clearly illustrated that to achieve what you have requires the team working, the networking, not just locally, regionally, nationally, internationally. That's how we can generate the results faster for our patients working in those very large networks. So congratulations to you for achieving that. Any questions at all? I see some of our colleagues. Anshuman. Oh, you're on mute, I'm afraid, Anshuman. You just have to click the button.
I know, despite after those couple of years of COVID also, not learned my Zoom option. So Raffaele, thank you firstly for a fantastic overview. I think from a pathology perspective also, just to thank you for your engagement and the academic and otherwise over the years as well. So it's been fantastic working with you. The question was in terms of small cell carcinoma. We know that clinically there are not many options, etc., and so on. But there is increasingly now the molecular subtypes that are being defined. Where do you see clinical trials, etc., coming on the back of those? Is there anything on the horizon? Thank you.
Thank you very much, Anshuman. That's a very, very important question. As you mentioned, now we've been able to identify at least 4 distinct phenotypes for small cell lung cancer: the inflamed phenotype and the neurophenotype. This is something which is a work in progress, and I think we need to start designing trials incorporating these phenotypes, perhaps at the beginning as stratification factors to test which strategies may work better in a distinct phenotypes. There are some studies which are already looking at a specific phenotype, for example, with PARP inhibitors or immunotherapy, because some of these phenotypes may have an exquisite sensitivity to PARP inhibition, for example. It will take a lot of well-designed clinical trials to prove this in clinical practice, because at present we do have mostly preclinical data with some validation data set. But I think the only way to try and not to dilute the benefit of a drug in the general population would be to try and dissect different phenotypes and give the right drug to the right patients. So you're absolutely correct.
Thank you.
Thank you. The more we learn, the more there is to do. I think that's the take-home message for any professor. Jane.
Yeah, just a quick question around future generations and early career researchers, clinical fellows. What advice would you give, or what key takeaways would you advise for their future careers?
So the first advice is to find a mentor and a sponsor, and to work in an environment which is nurturing you. And at the Christie we have a very good ethos. We want our fellow and our trainees to flourish, and we are here to act as a springboard, as someone else has done it for me. we act as a springboard for them to succeed. The idea is for them to be better than us at different levels over the years. So is to find a good mentor, to find a good environment, and also to seize the opportunity. A number of times you will feel that you're not up to it. I'm afraid you just need to close your eye and make the jump as everybody else has done it. Because if you do not go outside of your comfort zone, you will never be able to grow. And we'll be there to support you.
Great advice. Thank you.
Okay, we're at 7 minutes past the half past.
Thank you.
Fantastic session. So congratulations again, Raffaele. Thank you all for joining us.
Thanks a lot.
Have a good rest of day.
Okay.
Bye-bye.
Yeah.